In past, obesity was considered only a risk factor for cardiovascular disease. All obesity was considered to be a risk factor for all these diseases. But now obesity is categorized as a disease, and all these complications which you are seeing on the slide occur as a result of obesity. Adiposity or obesity refers to state of excess of body fat, and adiposopathy means that the body fat which is there gets sick and starts contributing to cardiometabolic diseases. And the big message for obesity is that treatment should be initiated right at the time of diagnosis without waiting for the complication. Rather, we should try to prevent all these complications. So adiposity is now renomenclated as ABCD, that is adiposity-based chronic disease. And most of the professional bodies has agreed to renomenclate obesity as ABCD because this allows obesity to be treated as a disease rather than a physical or a cosmetic factor, along with its chronic complications. And this also avoids stigma of overweight, obesity, which have fostered discriminating towards patients. And look at the number of diseases which can be caused by obesity. There are more than 229 plus diseases which are occur as a complication of obesity. You can see on the slide, hypertension, type 2 diabetes, NAFLD, and so on. So there are multiple mechanisms by which obesity develops. Neurogenic malformation occurs in obesity. Now, when you eat in healthy food like this, the nerves in the brain receive hormonal signals from your fat cells, from your stomach, and from your intestine, and the brain senses how much you have eaten. When you've eaten enough, it gives a signal of satiety. But when you frequently and repeatedly eat highly processed food, the nerves get damaged and the brain does not receive hormonal signals, and the brain does not sense how much you have eaten, and the individual continues to eat. There are several other factors for obesity. Obesity is a multifactorial disease, socioeconomic factors, environmental factors, behavioral factors, and even genetic factors. And obesity ultimately leads to a state of chronic inflammation, which is responsible for various complications. How do we diagnose obesity? In past, for several years, we have been diagnosing obesity on the basis of BMI, that is weight in kg divided by height in meter square. This has been used for several years. But the problem with this definition is, suppose somebody is a muscular body, then his BMI may be high, and yet he may not be having a greater quantity of fat in the body. So if you are measuring BMI, you must also measure other parameters like the waist circumference, more than 90 in females, more than 80 in males, and more than 80 in females. Waist hip ratio, more than 8 in females and more than 1 in males. Waist height ratio is frequently recommended as a good index of diagnosis of obesity, that is weight height ratio more than 50% of the height, that is 0.5. And the best method is body fat DEXA scan. If you have fat in your body more than 30% in female and 25% in males, this is considered as obesity. The other limitation of BMI is in Indians particularly, they may have metabolic obesity even with a normal weight, even with a normal BMI, because they have excess of metabolically active fat in their body. Now, the development of obesity starts right in utero for the entire lifespan of the individual. If you see, the genetic factors may be responsible, or the excess gestational weight may be responsible, then gestational diabetes, inability to breastfeed, And then as the child grows in the first decade, there's increased skinning time, which we see frequently, unhealthy eating habits, physical inactivity as he grows, poor nutrition, sedentary lifestyle, which is the lifestyle of the modern era, economic factors, environmental factors, social factors, behavioral factors, and perimenopausal women, the activity decreases. And when you get older, declining strength and mobility and sarcopenia plays a very good, very strong role in development of obesity. Now, when you have this excess body fat in the abdomen, it gets deposited in various ectopic sites. And all this ectopic fat deposition produces a detrimental effect on the various organs. So your fat gets deposited in the liver, it predisposes to development of type 2 diabetes. You have a fatty liver, you are bound to get diabetes in the next few years. When it gets deposited in the pancreas, it produces diabetes because it damages the beta cells. If it gets deposited in the perivascular space in the arteries, it produces ACVD, myocardial infarction, stroke, and so on. When it gets deposited in the epicardium, it produces HFpEF and AF. And when it deposits in the muscles, it decreases insulin sensitivity. And wherever it gets deposited, it produces chronic inflammation and insulin resistance, which are linked to multiple pathways of CV risk. Increased waist circumference is associated with reduced testosterone levels, elevated estrogen levels in men, and this may lead to hormonal imbalance that can also cause erectile dysfunction. So during the last couple of years, adipocentric approach has come to the forefront in patients with diabetes, even ahead of the glucocentric and renal approach. Any magnitude of decrease in weight is beneficial. If you decrease weight by 5%, it starts impacting insulin sensitivity and beta cell function. If the weight is decreased between 10 to 11%, the magnitude of the benefit is greater and the spectrum of benefit is wider, and it starts also impacting gene expression in adipose tissue. And if the weight loss is 15 or 16%, there's greater benefit and it starts impacting the inflammatory markers also. And here you can see if the weight reduction is more than 15%, your diabetes may undergo a remission, it may decrease cardiovascular mortality, and is very beneficial to patients of obese phenotype of HFpEF. So during the last couple of years, there has been a drug revolution in obesity. Now we have single agonists like semaglutide, which in the STEP trial you can see has shown reduction in weight by 14, 15, even 17%. And we have the SELECT trial, which has shown improvement in the CV outcome in non-diabetic obesity, meaning patient is not suffering from diabetes as one risk factor. And you can see the primary endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke has been decreased by 20%, which is statistically significant. And of course, the body weight is decreased and the waist circumference is improved. Then we have the dual agonists like tirzepatide, that is GIP-GLP combination. And these agents were tested in the SURPASS trial and the SURMOUNT trial. And you can see tirzepatide has shown decrease in weight to the tune of 9.5 to 13%. This is data from all the 5 SURPASS trials. And the HbA1c reduction was to the tune of 2.07 to 2.59. And look at the SURMOUNT trial, the weight reduction is to the tune of 22.5%. In CagriSema, which is a combination of cagrilintide plus fixed dose semaglutide, has also shown reduction in weight to the tune of 17%. And now we have triple agonist also like retatrutide, which has shown reduction in weight to the tune of 24% or so. And several newer agents are in the pipeline. So in times to come, as you can see on this slide, we will have multiple agents targeting obesity. So what has seen in the recent past is that the conventional methods of weight loss like diet, exercise, and the conventional pharmacotherapy, they decrease weight by 5 or at the most 10%. If you adopt an endoscopic bariatric procedure like sleeve gastrectomy, you may decrease by 20 or 22 or 25%. And bariatric surgery, of course, is 25 to 30% or even more. So what is seen is that the gap between the conventional treatment and the endoscopic bariatric surgery is getting narrower and narrower, and that's what we want to achieve. What is very important to realize is which is more difficult, losing weight is more difficult or sustaining weight loss is more difficult. Losing weight is not difficult, but if you lose weight, sustaining weight loss is very, very difficult. And this should always be borne in mind when you are adopting weight loss. Prevention, therefore, remains the key level which needs to start in utero and continue throughout life, as I've shown the slide in the beginning. So what are the positive trials of GLP-1 receptor agonist even in non-diabetic obese patients? Diabetes, we have several trials which have shown improved outcome, but let's see the non-diabetic. Now, this is the SELECT trial, which enrolled patients who has obesity and they were not suffering from diabetes. So BMI more than 30 or BMI more than 27 and some risk factor and semaglutide, the dose was gradually built up. And as you can see, there is a 20% reduction in the primary endpoint of non-fatal MI, stroke, and cardiovascular death. The p-value is less than 0.001. I've already shown to the SELECT trial with tirzepatide, and then now there are positive trials of single and double agonist in the obese phenotype of HFpEF. You can see this is STEP HFpEF trial. Again, this was seen in patients with HFpEF who were obese, and semaglutide was compared to placebo, and the BMI was more than 30. So the primary endpoint, you can see KCCQ scores improved significantly. The quality of life improved, and there was significant reduction in the weight, which is also statistically significant. The 6-minute walk distance improved. Adverse events were more in the placebo compared to semaglutide. And there's also a trend toward decrease in the cardiac disorders. The C-reactive protein is also decreased because inflammation plays a very key role in development of obesity and its complication. And then we had the STEP HFpEF trial in 2024 in diabetic patients. Again, obese patient BMI more than 30 and type 2 diabetes and HbA1c less than 10%. And again, you see KCCQ score improved significantly, weight decreased significantly, and the 6-minute walk test improved significantly. And what is also very important that the levels of NT-proBNP also shows a significant decrease, as you can see. And time to first HF event, as you can see, there's also a significant improvement. And if you look at the C-reactive protein again, is decreased. And when we look at the pooled analysis of both these trials, time to first HF event to cardiovascular death, there's a significant improvement in this parameter. And of course, the quality of life and reduction in weight was seen. And this led to the thought of conducting a trial in HFpEF in the obese phenotype with tirzepatide, which was presented recently in the AHA, the Summit trial. And again, the primary endpoint of this trial was a composite of death from cardiovascular cause, unlike the HFpEF trial with semaglutide, or worsening heart failure directly. In the previous trial, the primary endpoint was improvement in the quality KCQ scores and the weight. So here you can see the primary endpoint. Again, there's a statistically significant improvement in the patient who were given tirzepatide. And you can see, of course, the KCQ score also improved. So the big emerging question is, will injectable semaglutide and tirzepatide be classified as a heart failure drug only for the obese phenotype of HFpEF in future guidelines? Because both these drugs have shown improvement in HFpEF. Most likely they will be included in the list of HFpEF phenotype obese. Then we have positive trials in the obstructive sleep apnea. This is with semaglutide. You can see the hypoapnea index is improved, the weight is decreased. And this is the SURMOUNT trial with tirzepatide, which has shown also significant improvement in the apnea-hypoapnea ratio. And now we have positive trials in MAFLD, NASH, and MSLD. This is the phase 2 trial, LEAN trial, which has shown improvement in the NASH resolution. And we have this trial of semaglutide in NASH. Again, you can see there's improvement in the NASH resolution and also in the fibrosis state. And the ESSENCE trial with semaglutide, a phase 3 trial, is ongoing. And we also have now tirzepatide synergy NASH trial, which you can see is also showing benefit in MAFLD and MASH. So in summary, when we look at the achievement of these new drugs, GLP-1 receptor agonists, what do we find? Our desire in obesity to decrease weight. We have injectable semaglutide, we decrease weight by 15 to 17%. Oral semaglutide, 50 milligram, it was tested in a trial, is again shown decreasing by 16 to 17%. All these agents produce good glycemic control, HbA1c reduced by 1.5% or more. They produce ASCVD benefits. Several GLP trials are listed here. Heart failure, I already shown you the STEP trials. Flow trial was positive, and the lean and ESSENCE trial. So GLP-1 receptor agonists are very important drugs for managing the cardiometabolic complications of obesity. And here is the achievements of tirzepatide. They produce significant weight loss, 22.5% in the SURMOUNT-1. Then they have good glycemic control. In the SURPASS, in the SURMOUNT, it's up to 2 to 2.5. SURPASS CVOT is ongoing. Summit trial has shown improvement in HFpEF, and the synergy NASH trial is ongoing. So in summary, obesity is now categorized as a risk factor and aptly nomenclated as ABCD, adiposity-based chronic disease. Drug revolution in obesity is exciting, but stopping the drug when the goal is achieved or when side effects occur or cost factors, this results in regain of weighting due to relapsing nature of the disease. Sarcopenia is a big problem with all these new anti-obesity drugs. They decrease the fat mass, but they also decrease the muscle mass. And attempts should be made to minimize it by exercise and protein supplementation. Bimagrumab IV once a month is a human monoclonal antibody which binds to the myostatin and has shown increase in the muscle weight and muscle hypertrophy in phase 2 trial. And the drug has also shown reduction not only in the body fat mass, but increase in the lean fat mass by 7% compared to placebo. So we are amidst drug revolution in obesity, and hopefully in times to come, we will have better agents to holistically target obesity. Thank you very much for your time.
Okay. Thank you, Dr. P C Manoria, for giving us a good glimpse of all the recent drugs which are useful in the management of obesity. I think a couple of points which needed to be, which one should clear. Whether injectable semaglutide is available in India or Zempic.
Injectable semaglutide is likely to be available next year. At the moment, it's not available in India.
Okay. So is it more potent in reducing weight as compared to oral semaglutide?
Oral semaglutide, 14 milligram reduces weight by 5 kg, but the trial with 50 milligram oral was conducted and has shown reduction in weight by 15%. This is not officially marketed at the moment, but the trial has shown reduction to the tune of 15%. So injectable semaglutide, 15, 16, 17%, oral sema 5, that is 14 milligram, and sema 50 milligram oral, 15% reduction.
And does injectable semaglutide has the same CV benefit also as shown in the with oral semaglutide?
The injectable semaglutide, we have the leader trial, we have the sustained 6 trial. Leader trial not only showed benefit in the primary endpoint cardiovascular death and MI by 13%, and also showed reduction in cardiovascular mortality and all-cause mortality. And the sustained 6 showed a 26% reduction in the MACE and a massive reduction in stroke to the tune of 39%. So we were having data of GLP-1 receptor agonists in diabetic patients. The SELECT trial was the first trial to show benefit in non-diabetic obesity. So previously trials were conducted in diabetic patients. We had no data whatsoever when these drugs will be used in non-diabetics, will they benefit? And they have shown that they not only benefit obesity, they also improve the CV outcome, as shown by the SELECT trial and the trials of tirzepatide also, the SURMOUNT-1 trial.
Okay. And So many of times we have seen once the patient starts these drugs, they feel a lot of belching, bloating, and abdominal discomfort, which is very difficult to adjust with, and that lead to a lot of non-compliant issue in people. Many people, many patients have stopped using these drugs. How to treat these complications?
Firstly, the patient must be determined to lose weight. Nausea and other side effects, gastrointestinal side effects, are seen in 5 to 10% of patients. If the drug is continued, usually they wean off. Or if you are having severe nausea, you should, suppose you have started on 3, at 7 it starts getting nausea. You can reduce the dose back to 3 and then gradually increase. Instructions regarding diet should also be undertaken. They should not take any fatty meals and other things. So usually this would, but some of them, of course, 5 to 10% develop these GI side effects.
And how long one should take these drugs? Suppose we have got a good reduction of 10 kgs or 5, 15 kgs, suppose.
It's just like lipid management or hypertension management, diabetic. As long as you can take, as long as you are tolerating, because once you stop it, the problem is regain of weight. And when the weight regains, it reaches up to 70 or 80% of your previous weight, and the muscle mass is not increased. Most of the regain of weight is due to increase in the fat mass. So that should also remember. So treatment of obesity is a long drawn out process, just like treatment of hypertension, diabetes. It's not a shortcut. If you stop it, it will relapse. It is relapse and recurs. So that should also. But now with newer drugs which are in the experimental stage, that they may increase lean mass or they may not allow lean mass to drop, the future may be better than at present, because all these anti-obesity drugs, they also produce muscle mass also decreased. So not only your fat mass decrease, say 10-20%, your muscle mass will also decrease. And that is one of the serious concern in patient, because feels that if his muscle mass is decreased, he may not be able to do his work which he was doing.
Okay, thank you. I think there are no more questions. So thank you, Dr. PC Manoria, for enlightening us with all the latest advancement in the management of obesity. Now we have our second faculty who's already logged in, Dr. Naveen Bhamri. Dr. Naveen Bhamri is the Director of Lab and Director of Cardiovascular Science, Max Hospital, Delhi. And he has a lot of interest in doing coronary interventions as well as non-coronary interventions also. And he's also into a lot of TAVIs and other structural heart disease also. But today he's speaking about some different topic. What are the interventions which we can do as a intervention cardiologist when we are treating hypertension? So what are the techniques, what are the latest advancements, and how what are the patients one should search for using this technique? To go through the entire spectrum of this therapy, I'll hand over the podium to Dr. Naveen Bhamri to enlighten us about this latest intervention in hypertension. You know.
Thank you, Pankaj. Thank you, Pankaj, for giving me this opportunity to share my thoughts about the role of intervention cardiologist in treating the resistant hypertension. Basically, as we all know, resistant hypertension is a condition when the blood pressure is still high, more than 140/90, when you are using three antihypertensive drugs at their maximal dosage, and the fourth one is a diuretic also. So when the blood pressure is still high, even after using all the four drugs at maximum possible dose, including diuretics, and still the patient is complaining that, doctor sahab, my blood pressure is still high, what next? So now after the so much of the discussion about the renal denervation therapy, what we can offer as a cardiologist to the patient is, though 10 years ago when this therapy came, the result was not as good as nowadays what we are doing. So we can offer the renal denervation treatment for such patients, because what is the mechanism behind. Basically, we have to break the, and the mechanism involves disrupting the sympathetic nerve signal between the kidney and the brain, which play a key role in regulating the blood pressure. So I'm going to share my slides. A complementary treatment option for hypertension patients. So what are the Indian challenges of hypertension control? what why RDN? Why renal denervation therapy for the treatment of hypertension? Hypertension has a prevalence of 6.64% in the year 1988, which increased to 36.4 in 2003. So they screened 16,070 participants, and the 1609 was analyzed. Only 14% patients had a normal blood pressure. So the prevalence of hypertension when we take a blood pressure of 140 by 90 is 24.9%, and only 3% on antihypertensive medication at the time of survey. So you can see, so there is a lot of the prevalence is too high, but only few patients are on the antihypertensive medication. Systolic and diastolic hypertension, higher prevalence in men. Stage 1 and 2 hypertension among among all the population, including the older individuals. And what were the risk factors? Sedentary workers, high BMI, smokers, history of ischemic heart disease, non-vegetarians. Predominantly in fish eaters and the mustard oil users, they had lower risk of high blood pressure, that is hypertension. The market survey results show that more than 50% hypertension detected accidentally. Nephrologists and diabetologists have more than 20% resistant hypertensive patient as compared to the other physicians. 63.4% participants went from the GP to other specialists, and only 5% reached to the intervention cardiologist. Young individuals are more receptive to this therapy for the hypertension treatment. 40 to 50% hypertension patients have comorbid conditions like coronary artery disease or COPD, and more than 50% patients actively seeking alternative to the oral medications. So there is definite a challenge for the acceptance of this therapy. Why we are going for the RDN when there are drugs? So there are some certain advantages that you can control your blood pressure with a simple method of 30 minutes or 25 to 30 minutes. So hypertension is an Indian health crisis. Uncontrolled hypertension dramatically increase the risk of heart attack, heart failure, stroke, kidney failure, and the eye disease. 53% of the treated hypertension patients don't have their blood pressure under control, and the Health Ministry of India has set a target of 25% relative reduction of prevalence and in the prevalence of hypertension by the year 2025. So existing treatment can fail in reaching hypertension control due to non-adherence. Why non-adherence? Many patients cannot tolerate the polypharmacy and abandon it. So hypertension is the leading preventable cause of heart attack, stroke, and death. If you can reduce the 10 millimeter of systolic blood pressure, so 10 millimeter absolute reduction in the systolic blood pressure, reduce the 20% relative risk reduction in the MACE events, 13% reduction in mortality, 28% in heart failure, 27% stroke, and 17% in coronary heart disease. So hypertension is the leading preventable cause of heart attack, stroke, and death. We all know 20% relative risk reduction occur with just 10 millimeter reduction in systolic blood pressure. So you can see here what are the advantages of decreasing the just 10 millimeter mercury systolic blood pressure by any means, and 13% reduction in the relative risk reduction of all cause mortality. Renal denervation provides a complementary approach for difficult to treat patients. In this, sympathetic signals to and fro, both afferent and efferent pathway from the CNS modulate the renal function and total body sympathetic tone. Renal denervation targets and inhibits the sympathetic nerve activity. This is an interventional approach to decrease the sympathetic drive. Energy is delivered to the renal nerve through a special catheter called the Simplicity catheter, which we introduce inside the renal arteries and just ablate it multiple times, 14 to 18 times. No permanent implant is left behind. This therapy takes around 20 to 30 minutes, and the little painful therapy, so you have to take some give some sedation, that is conscious sedation, nothing else. And the results you can see even on the table, and the results are are the sustained results. You can see the sustained results over a period of years. So Simplicity Spiral renal denervation system, it is a versatile system. One catheter size fits all the eligible anatomy size. It fits between 3 to 8 millimeter in diameter. Very easy to use. plug and play design. And this you can see here, this is the radio frequency generator, and there are four, the electrodes on the each simplicity catheter, and you can ablate one by one all the fours, not more than one time. Significant, what is safe and sustained BP reduction, you can see in the spiral hypertension program from 2017 to 2022. Real world experience with this catheter is more than 25,000 procedures performed with this Medtronic RDN system. If you can see the safety evaluated across all the studies and population with the spiral hypertension clinical trial program. And you can see here, in the absence of medication and in the presence of medication, from on table to 3 years, at least there is a sustained reduction in the blood pressure from 10 millimeter to maximum 21 millimeter of mercury. But this is in the trial, but clinically we can see, I have observed up to 30 to 35 millimeter of reduction in the systolic blood pressure after the renal denervation therapy, after 6 months after the RDN therapy. So RDN demonstrated always a on effect on 24-hour blood pressure lowering. You can see here, in the absence of medication, even the presence of medication, nighttime early monitoring, there is sustained reduction. If you can see the safety outcome, there is a zero mortality, no end stage renal disease. You can see there is no renal artery perforation or dissection I've noted till now. Hospitalization for hypertensive crisis, zero. New renal artery stenosis more than 70%, zero. Hospitalization for hypertensive crisis, yes, one, but that too after 48 months of the therapy, and the embolic event, even that is after 48 months of therapy. So you cannot directly label it as a the side effect or the safety profile of the RDN. So patient selection and consideration was, there were various consensus statements published in 2018 till 2023, and now it is there in the European Society of Hypertension Treatment, RDN as a class 2B indication. So what are the the patient selection? You have to, the patient should be, you have to rule out the secondary hypertension basically, and the, you have to rule out the white coat hypertension. Select the patients who are not controlled by using more than 4 drugs, including diuretics at their maximal dosage, and consider the urgency of reaching the blood pressure control after multiple months of medication attempt without reaching the control. So RDN selection consideration, blood pressure, if the blood pressure is more than 150 by 90, despite the prescription of the guideline directed approaches taking account into individual patients, rule out white coat and secondary hypertension. Intensive discussion with the patient and the family is must before going for the therapy, because there are certain patients who cannot see the result on table, but later on they can see. So they must, you must teach them before that, yes, this is a treatment option, but you can see the result. There is a the reduction of 10 millimeter to 30 millimeter of mercury. You have to tell the patient before going for the therapy. RDN is indicated for use in uncontrolled hypertensive patient. Spiral hypertension clinical program aligns with the ESC ESH guidelines and ESH, that is European Society of Hypertension statement on RDN, focusing on patient in the context of the clinical studies and taking into account patients' preferences. In addition, RDN is being studied in patients between 150 and 180 millimeter of mercury on 0 to 2 or 0 to 3 medications. Thank you so much.
Thank you, Dr. Naveen, for an excellent deliberation. I think there are few questions. I think very short time. What is
Yeah.
the patient selection criteria in your clinical practice, and which kind of patients do you select when you choose these patients for RDN?
So, Pankaj, whenever there is a resistant hypertensive patient, we all know what is resistant hypertension.
Yeah.
If blood pressure is still more than 140 by 90 on maximum tolerated dose of the guideline directed antihypertensive medications, including diuretics. Secondly, if there are certain patients who are not tolerating the drugs, antihypertensive drugs, वो कहते हैं कि मुझे पीडल इडीमा हो जाता है कैल्शियम चैनल ब्लॉकर लेके, मैं ये drug tolerating. There are certain subset of patients in whom also we can use the RDN as a the choice of therapy for the resistant hypertension. But the main is uncontrolled resistant hypertension despite using all the 4 drugs. Second, intolerant to the drugs if they are not using all these drugs. And the rule out the secondary hypertension always, because in 10% of the patients there is a secondary hypertension like renal artery stenosis and all. If it is there, then treat the secondary cause of the hypertension first and then go for the RDN if they are still uncontrolled. So renal artery stenosis there, you must
Okay.
go for the renal artery angioplasty and then see the result. If even after that, then only you can go for the RDN.
Thank you. Thank you very much. And one last question: how much BP reduction are we expecting when we use this therapy?
So in the trials, it has shown 8 to 10 millimeter reduction in systolic blood pressure initially. But if over a period of 3 years, if you, in the trial showed that there is a up to 30 to 35 millimeter reduction in the systolic blood pressure. And if you can reach the 10 millimeter reduction in systolic blood pressure, you can reduce the relative risk reduction in the mortality by almost 18 to 20%. So it is again a win-win situation if you reduce 10 millimeter systolic blood pressure. So the trial has shown that 10 millimeter to 30 millimeter reduction in systolic blood pressure by RDN therapy.
Dr. Bhamri, one of the problem with RDN is when you complete the procedure, how are you able to know that the procedure has been successfully done, just
Yes,
as
yes. There are no endpoints actually. Basically, there is no parameter there is no angiographic parameter or nothing else. So there are. This is again a challenge, and because if you are doing angioplasty, you can do an IVUS, you can see angiographically also that my stent is expanded and there is no thrombus. But in RDN, there are no clinical or indicators or predictors by which we can say that yes, my procedure is successful. It is only the clinically you can see yes, there is a reduction in the blood pressure and all. There is a reduction in the dosage of the medications over a period of 3 months to 6 months. But yes, you are right.
Yeah.
There is no predictors on table that you can see that yes, it is successfully done.
and the Simplicity 3 trial was negative initially, but a long-term follow-up has shown very good results.
Yeah, yes, sir. Yes, spiral, Simplicity spiral.
I think with this, we conclude this session. And thank you, Dr. Naveen, for sparing your time and joining us. Thank you very much.
Thank you.
So the next session is on IVUS, the third eye of the interventional cardiologist. And the speaker for this session is Dr. Pankaj Manoria. Dr. Pankaj Manoria, please.
Okay. I hope my slides are visible.
Yes.
Yes.
Yeah. Okay. IVUS has now become like a third eye of intervention cardiologist now. Now, gradually, previously the infiltration of IVUS was only around 5 to 10%. But now in America, it has increased to almost 15 to 20%, and also in the European countries. In India, also, it is picking up gradually with time. What is IVUS? IVUS is a medical imaging technique which allows us to have a detailed look into the blood vessels of our heart from inside out. How does IVUS work? IVUS basically a reflection techniques. What happens in IVUS? IVUS reflects ultrasound waves. These ultrasound waves reach the target and they are reflected back. Now, the quality of image or the image or morphology image, it all depends upon how much is the reflection from the target. If the target from which the IVUS has been reflected back, it's very strongly, you get a bright image. If the reflection is weak, you get a dark image. That is this principle. This is the main principle of how the intravascular ultrasounds is hacked. This is just to show schematic diagram or animation of how the IVUS. You can see the transducer emitting ultrasound waves. These waves touch the vessel wall and they are reflected back, and then the computer process these reflected waves and convert them into images, and which are then you can see on these screens. So whenever we do IVUS, we see this type of image first. So we know that all the vessels is a three-layer structure. Now the first thing one should do when we do IVUS is to see for the black rubber band-like structure, the circle, black rubber band circle. And that black rubber band circle is the media. Media appears black because media is mainly composed of smooth muscle cells which reflect the ultrasound waves very poorly. So you see a very dark structure. Now, outer to media is the adventitia, and inner to media is the intima. And intima is nothing but the plaque. The plaque of atherosclerosis is just the intima. Intima thickens as the atherosclerosis progresses. And one more important measurement is the outer border of media is called the external elastic lamina. So it is very, these measurements are mainly done with EL and also media to media. How is different from angiography? Now, just to give you an example, how angiography can lie sometimes. If you ask you what this picture is, it appears like this some animal is walking. Once you see a complete picture, the shadow is basically of the two girls walking, which is appearing like a gorilla or the animal. The same, the shadow walls is completely different from the reality. What we say, seeing is believing, but imaging is actually knowing what is happening inside. Angiography has its own limitations when it comes to sometimes in the ostial left main, it can be ambiguous or bifurcation lesions, eccentric lesions, diffuse disease, vessel shortening. So all these things sometimes are not very clear, and angio lies sometimes in all these subsets of patients. This is the limitation of angiography because it is only two-dimensional structure. So with angiography, what you see is not always what you get. But in IVUS, actually, what we see, IVUS is what we actually put the catheter inside the vessel and have a picture from inside the vessel. This gives us a great clarity as to what is happening inside the arteries and many detailing structures which what we cannot see on angiography. Sometimes a diffuse disease, a lesion which is 50% diffuse disease, sometimes it may appear a normal like looking structure on angiographically because it's a diffuse disease. But once we do an IVUS, we found that the normal looking structure has a plaque burden almost 50%. So sometimes we mix the plaque burden on angiographically. A lumen eccentricity also plays a very important role. If sometimes eccentric lesions in certain views, you must look like it's a normal structure because it's again a two-dimensional structure. So once we take another view, sometimes we realize that. But in IVUS, or just put an IVUS, you can see a complete overview of that the lesion. IVUS help a practical approach of IVUS can be it helps in all answering all three questions. Should I stent this lesion? How should I use the stent, and did I do it right? That means whether to do the procedure, how to do it, and at the end whether I have done it correctly or not. All these three questions can be answered correctly. It's a tool to optimize angioplasty. You can get a clear view of the stents, the malapposition, expansion, everything can be assessed in detail. What we can't see well angiographically, and there the main indication of using is stent expansion because we know that underexpanded stent is the main cause of stent thrombosis. But in IVUS, we can see clearly the expansion of stents. If it's underexpanded, we can intervene or do a strategy depending upon the results. So everything can be seen on IVUS. Post angioplasty, the complications sometimes there's a dissection or some intramural hematoma or what's a spasm, everything. What we in angiographically, there's sometimes a lot of doubt as to what is causing the haziness at the distal portion of the stents, but such things can be seen in detail on intravascular ultrasound. A picture can say 1,000 words. This is just to say how detailing what we can get on intravascular ultrasound on OCT cannot be imagined on angiographically. What are the advantage? What are the evidence do we have? There are a number of trials in which they have studied whether intravascular ultrasound is beneficial or not. The largest study was the ADAPT-DA study, in which what they found that when you do IVUS guided angioplasty, there's a 38% less myocardial infarction as compared to those angioplasties in which IVUS was not used. Also, that there was almost a 50% reduction in the stent thrombosis. So stent thrombosis rates have reduced by almost 50% if you use the IVUS. And IVUS, once you do IVUS, you change your strategy almost 2 out of 3 times. That means either in the form of some balloon size, extra balloon, stents, or whatever you do, you change your strategy almost 2 or 3 times whenever you do IVUS. Though it appears costly, but I can say it is cost effective because the question is caution should not be how much it is cost to use it, But the question should be how much it will it cost not to use the IVUS? Because if your patient lands up into restenosis, stent thrombosis, it not only produce a financial burden to the patients, but also has increased mortality in such patients. To be precise, the lack of precision is dangerous when the margin of error is small. So such precision is required when we do complex angioplasties like left main. Best utility, if you ask me, what are the best utility of IVUS? It is in left main, bifurcations, long lesions, ostial lesions, instant restenosis, and complications. These are the main indications of using the intravascular ultrasound. In IVUS, I can say this is one of the it has been given a class 1A recommendation to use IVUS in left main cases. So just to say, in patients undergoing PCI, IVUS guided stent angioplasty reduces mortality in almost every clinical scenario. And what is more important than improving patient survival after stenting? And all these consensus, this is just to give you how Mona Lisa will appear on CT angiography, IVUS in OCT. Detailed resolution, what we get with intravascular imaging cannot be imagined or cannot be seen on angiography or CT angiography. I can say IVUS or intracoronary imaging is the third eye of intervention cardiologists, or it's like a glasses for modern day intervention cardiologists who do not like blunt decisions. Thank you very much.
Dr. Pankaj, we have two important imaging techniques, OCT and IVUS. When do you prefer IVUS? When do you prefer OCT? And what is the difference between both these techniques?
Main indication of OCT is when we need to look in detail at the intraluminal pathology. That means in like ACS, we want to look at what is the cause of ACS, whether it's plaque rupture or plaque erosions. So when we see a near field structure, intraluminal structure, we want to see in detail because the resolution of OCT is almost 3 to 4 times that of IVUS. It's almost 22 microns of OCT, and IVUS is around 40 to 50 microns. So you detailing structure, detail of structures, what you see is useful in OCT. Whereas IVUS is we see a resolution of, but now with HD IVUS the resolution has increased, and IVUS I think has an edge over OCT when we are dealing with ostial diseases, because ostial cannot be seen clearly with OCT. When we are doing zero contrast, we are planning, then the such patients in CKD patients, IVUS has an edge. But otherwise, both these modalities are very useful, and it is in doing angioplasties.
Second issue, should all left main angioplasty must be done with IVUS or imaging, or there are certain
I
subsets
think
which
if you
can...
see the recent ESC recommendation, it's clearly says it's a class 1A recommendation. So I think all left main, if possible, should undergo image guided angioplasty.
And in OCT, do you use dye?
Yes, OCT, now there has been concept that you can use a saline also, but it is useful only in right coronary artery. It gives the equal picture or some. But in left system, because the left main artery is very big and sometimes it is very difficult to replace the blood vessels with the saline. So that is why it is mainly used in right coronary artery, not in left coronary artery.
So on an average, how much dye is used during the OCT examination, say for the left-sided?
So for each injection, around 10 to 12 ml dye is used for each injection. And depending upon the injections you take.
So faced with a patient of CKD, what would be your choice and how do you carry it? Suppose somebody has a creatinine 3.5 and a severe coronary artery disease, what
I
would
think
be
the
your...
preferred modality should be intravascular ultrasound. The people have tried saline OCT for zero contrast, but I think it is not that effective. And the best strategy is to use HD IVUS for zero contrast PCI.
And what is the evidence that imaging guided PCI has changed the outcome of disease? What is the decrease in the
I think
mortality
we
or...
have number of studies. The recent meta-analysis have shown that stent thrombosis is reduced by 50%. Peripustular MI has reduced by almost 25 to 30%. In fact, all-cause mortality has been reduced by almost 18%. It has been shown.
Dr. Bhamri, any questions from your side? I think he's not. Yes, Dr. Bhamri, please.
Pankaj, I have actually saved his name as a Gary Mins of India for IVUS. So so for me, he is the master of IVUS. I have no questions asked. Yes, he is. How many OCTs and how many IVUS you are doing every month? Just let me know, Pankaj.
I'm doing almost 30 to 35 IVUS, almost all angioplasties, if possible, are image guided. OCT machines we have recently acquired only few days back only. So now I'll be doing OCTs also, but till now I was doing only IVUS.
So if you have a choice of doing bifurcation lesion, uh, what is your preferred modality, whether IVUS or an OCT,
In,
left mid
in
bifurcation?
frankly speaking, I'm very much comfortable with HD IVUS. I don't need an OCT, but if the ostial is, I think if the left main is there, but ostial is spared, I think then I can use an OCT also. Because for OCT, we need to clear the blood vessels. So we need to good engagement of the guide is very essential. Sometimes in ostial involvement of the disease, we're not able to engage the guide properly, so we don't get a good picture. But if I think, but bifurcation, I can say if whether distal crossing or proximal crossing is seen much better with OCT than IVUS. It's very clear. But otherwise, both these modalities are very good.
You are using IVUS in CTOs also for the.
Yes, for mainly CTOs for proximal cap puncture, IVUS guided. Sometimes we do use against a very good modality. Here comes the role of IVUS. IVUS should be preferred over OCT when we are doing an CTO interventions.
Thank you so
So, Dr.
much.
Pankaj, are there any subset of patient where you require both in OCT also as well as in IVUS?
Mm,
Maybe complementary to each other, but are there any subset you will also like to IVUS, you will also like to see on OCT?
like sometimes in IVUS, suppose we are doing a CTO intervention, something we are suspecting infraluminal pathology. We are doubt about what is plaque prolapse or what is it. So to see the infraluminal pathology, OCT is always preferred. So sometimes we may use, but it's very rare to require.
And in calcified lesions, OCT has a much better, visibility of calcium as compared to the IVUS. So whenever there is a, the thrombotic calcified lesion, we can use both the modality IVUS as well as OCT in such cases.
Main limitation of IVUS is the depth of the calcium cannot be calculated because IVUS cannot penetrate the calcium. So you don't see the depth of the calcium. But OCT we can clearly see the depth of the calcium because it is very much visible.
Any other question, Dr. Bhamri, or comments?
Yes, I'm done with my questions. He's a master. I know he's a master of IVUS.
So I think with this, we conclude this session. Thank you very much, Dr. Bhamri, Dr. Pankaj, for a very excellent and informative talk. Thank you very much.
Thank you. Thank you.
Thank you.
It was very good.